Thank you for being here. Welcome to House Labor, Health and Social Services Committee. This is our second committee meeting where we're hearing information that our committees received from various organizations, just to hear different perspectives and gain insight as we draft laws and consider policy change. So thank you for joining us. This morning, we have two presenters. The first one will be the Wyoming Association of Sheriffs and Chiefs of Police. And the second one will be a report that we received that was an organization by the name of Citizens Commission on Human Rights International. And so I'd like to welcome up WASCOP first. Good morning, Mr. Thompson. And I believe we have a co-presenter online joining us as well. So if you would just state your name for the record and who you're with and your co-presenter as well, and we will hear your presentation.
Thank you, Madam Chair. My name is Alan Thompson. I'm the Executive Director of WASCOP, which is the Wyoming Association of Sheriffs and Chiefs of Police. Online, we'll have retired Chief Roy Eckert from the Powell area. He'll present a lot of the meat and potatoes of what we're talking about today. We've been asked to talk to the committee about CIT, Crisis Intervention Team. And I want to start a little bit by kind of introducing WASCOP. I know that a lot of you have seen us, our presence here over the years, but our legislative efforts are really just a sliver of what we do. We do have 3 employees. We advocate for law enforcement across the state. I like to tell everyone that I'm in the best job in the world because I get to advocate for good law enforcement. We operate several grants that help agencies with training, equipment, and I think one of the most important things that we do is keep up that communication between law enforcement entities across the state. So we're a conduit of that communication and education opportunities, training opportunities, in ways that we can help agencies that are experiencing something they haven't before. It's probably been experienced by another agency somewhere in the state. So connecting law enforcement professionals to help each other across the state, I think is the most influential and the thing that I'm most proud of. My career in law enforcement started with the Sheridan Police Department in 1998. I moved over to the Sheriff's Office in 2006. I retired from the Sheriff's Office after a total of about 25 years in law enforcement, and at the end of 2022, serving the last 5 years there as sheriff. I had the opportunity to come into this position. WASCOP, I'm proud to say, is one of the few organizations in the United States that's a combined police chief and sheriff's association. Most states have separate entities that advocate for sheriffs and advocate for chiefs. And also, our membership does include some state agencies. So our membership is any law enforcement entity administrator or leader, from, Highway Patrol, DCI, down to the smallest police department in the state. We were successfully combined in the late 1900s. Late 1900s, that sounds like that was a really long time ago, but it seems I do want to say that, so those organizations did exist separately throughout the 1900s, but in the 1990s, the organization combined into what we see today, and then shortly thereafter brought on their first employee. My predecessor was the first employee of WASCOP, and I'm the second executive director that we've had that's, not like a president serving in law enforcement and serving on the board. We do have a board of 7 members that are comprised of chiefs and sheriffs from across the state, and that's who I work for and who I report to. So it would have been last year, in 2024, early in 2024, Chief Eckert was planning to retire from the Powell Police Department, and he's been instrumental in a couple of things for WASCOP, providing the management services assessment centers for promotional processes that we do for agencies across the state free of charge. And he's was brought on to manage that program and to kind of kick our CIT program into high gear and help develop that across the state of Wyoming. We'll talk a little bit more about the grant opportunities and the training after Chief Eckert has had the opportunity to explain what CIT is. But I'll also just mention that I became involved in CIT as a street officer at the Sheridan Police Department, and then later on as an administrator at the Sheriff's Office. I've had the opportunity to instruct in some of the classes that we'd offered in Sheridan, and I find the program to be very beneficial for our officers and agencies across the state of Wyoming. And a little bit about Chief Eckert. He, as I said, the former police chief in Powell. He started with that agency in 2003 after some time in other law enforcement entities across the region. And he ascended quickly, becoming the chief of police there in 2011. So he served as the police chief for well over a decade. And during that time and even before, was very instrumental in CIT in Park County. And when he came on board with WASCOP, we were lucky to have him because by then he'd been involved in CIT International. And he currently serves as the president of the board of CIT International. So if there's a resident expert in this part of the United States, I think that would be him if we're going to be talking about CIT. So I would really invite the Madam Chair, the committee to ask questions as we go through this today. I think that Roy is a wealth of information about CIT, and we're really excited to have that conversation. I'd love to turn it over to him to delve a little bit more into CIT for us. Thank you.
Thank you, Mr. Thompson. Mr. Eckert, please.
Madam Chair, committee members, nothing like setting the bar high. Alan, I appreciate the introduction. Yeah, CIT as a whole has been around Wyoming for a little while, but we always seek clarification because we live in a world now of acronyms and buzzwords, and they float the hallways, and we see it, nationally and at state and local when they talk CIT. So I wanted to clarify a little bit about what CIT is. So when we talk CIT in this context, we're talking crisis intervention teams. And that's an important division right there. It's not training, it's teams. CIT is a community-based program that requires more than just a law enforcement presence at the table. So training is a component, but the team is the concept. So CIT was spawned out of an incident in Memphis in the mid-'80s, came online in 1988 as the community members came together after an incident where individuals suffering from behavioral health crisis lost his life in a law enforcement contact. And the community came together and obviously was upset, but then had the discussion of how can we do this better? So the bringing together of law enforcement, mental health, advocacy groups, people with lived experience are critical at the table, and family members of those with lived experience. So CIT is about bringing together all those people and identifying gaps within the system. So each CIT program within the state will have a steering committee that will be represented by those 5 stakeholder groups to identify gaps locally. We're working currently to develop a statewide steering committee. There will be state level individuals. We have representation from the Department of Health, from the Sheriffs and Chiefs Association, from NAMI, who's a critical partner in this conversation to identify gaps at the state level and be able to bring together what's happening at the local levels. When you look at how we got to this point, we hear constantly about our law enforcement the best to respond to a mental health crisis. I think law enforcement as a whole would agree that no, we're not. But in our communities, we're what's available 24 hours a day, 7 days a week, 365 days a year. And we tend to have, in Wyoming, we talk about our lack of resources, and we talk about the lack of people available to respond. But in reality, nationally, we have the same crisis taking place. When you look at it per capita, we're lined up very similar. And actually, Wyoming is ahead on a lot of things that are being done at this current point in time. When you look at the whole deinstitutionalization period of time, so in the 50s, there were over 558,000 mental health beds in the United States. And as you moved into the mid-90s, we reduced that number down to about 74,000 for an entire state. Now, I'm not saying that everybody that was in the institutions needed to be there. Obviously, there was some abuse to that system also, but there were a lot of people that needed that ongoing care and help. And as a result of that process, they now are living in our communities. Now, part of that is the therapy, the mental health stuff we've learned since that time, the medications that are available. We've been able to treat and diagnose a lot more things than we could in the 50s. But moral of the story is we have a large number of people with a behavioral health issue living in our communities and a lack of resources to be able to address those. So how do we as a community better address those locally? And that's that relationship of bringing together law enforcement, mental health, people lived experience, and those family members, advocacy groups. Now, as far as in Wyoming goes, we were very fortunate. In 2008, CIT International became international, and they incorporated and started spreading their model a little wider across the country. And we had a group of mental health professionals, Madam Chair, I think you were involved in some of that at the time, that brought CIT back to Wyoming. And we had about 5 counties very active in attending the CIT programs, but we were still learning in what that might look like. Mental health came in, put on the training for law enforcement. I'd been involved with the training for about 3 years. I became chief, and then at that point, the mental health trainers in the room looked at me and said, "Okay, chief, now what do you want to do?" I'm like, "Excuse me?" That's where I began to understand the law enforcement role in all this, the community role, and how we bring all this together. So we've had 5 counties now that have been sharing their experience with other counties to help broaden that training across the state, but still working on the program development component of this. There's been a need for a long period of time, I think, to have a statewide conversation of how we can integrate together to be able to share resources, to be able to share experiences, to be able to share trainers and what works and what doesn't work. And we're at that point now of being able to have that opportunity. Over the last year, we've been building into the fidelity of the program, right? So as we keep talking about CIT as a training, but not the program part, we got a lot of training taking place. Now we're building programs. And we've been able to do that through some funding we received from the Department of Health. Alan, if you want to touch on that some.
Mr. Thompson.
Madam Chair, thank you. I came on board with WASCOP in the summer of 2023, and in the spring of 2022, we entered into a contract with the Wyoming Department of Health to expand, professionalize, and expand CIT delivery across the state of Wyoming. So I have the unique opportunity to have been the recipient as an administrator of those resources with my agency, and then move into a management role of that grant opportunity. So with that grant, that partnership, the statement of work for that grant included securing and training the trainers, so selecting qualified personnel and getting them the adequate training to be ongoing trainers across the state, and then provide that logistical support. So we started off with that, and I think part of that transition time with me coming in as the executive director, there was about a 6-month period there where we had a temporary executive director at the helm. So when I hit the ground, we were trying really hard to ramp up the delivery of CIT across the state. So we were leaning on people like Roy in the administration role back at their agencies to help provide these trainings across the state. And then move into when he came on board with us, that's where we were able to extend that grant 1 more year and continue to use the funding that was already appropriated to really get us to that point where we have, kind of this idea of a statewide symposium, a statewide collective of CIT trained individuals and professionals spanning not just the law enforcement realm, but all of those partners that we would work with when we're putting on a CIT. So what type of resources do we have in our community, and who would be those people that we would want helping to train our law enforcement, and who would be the people that we would want in the room? That includes fire, EMS, law enforcement, any of the mental health providers on the community level. And really the grassroots part of that is the peer counselors, the people that are just in the community advocating for their friends and neighbors. So getting that conversation going in the communities, and then understanding that counties are very different across the state. You know, if you look at the population base of Laramie County and Natrona County as opposed to Weston County, Niobrara County, Washakie County, some of those resources that we take for granted in some of our larger communities just don't exist in those smaller ones. So how can we regionalize this approach to CIT and bring in those resources that that exist maybe a couple towns away or maybe a county or two over? So we started having those conversations. We're fortunate to have Roy kind of steering that. So I think I'll probably let him talk about more about the CIT meeting that we had last year and what we're looking forward to doing with that this next year. But I'd also, I mean, we're throwing a lot of generalized terms at you, Madam Chair. If anybody has any questions so far or want us to delve a little deeper into any of these things that we've talked about, please let us know. But I'll turn it back over to Roy to talk about the CIT gatherings that we've had here in Wyoming.
Sure. Mr. Ecker.
So the law enforcement in jails, as a result of what we were talking about before, have become the de facto go-to when it comes to mental health conditions. You guys have all heard stories of people sitting in a local hospital for 6 to 9 months waiting to get care in the state hospital. That's not pointed anybody in direction. That's just a reality of the system that we operate in. So as we work to build relationships, as we work to train better, I would say, you know, goals of CIT are to bridge the gap between law enforcement response and mental health care by forming partnerships. And I would say partnerships and relationships. You know, when we started CIT, there was a huge amount of frustration on the law enforcement side with mental health because we didn't feel they were doing all that they could do. There was always frustration from mental health because they didn't like the way law enforcement approached something or the way that something was dealt with by law enforcement. So by building these relationships and learning that we all have the same end game goal, we just have a different set of rules we have to operate within, we begin working together more effectively. So as a result of the process we're working in now, we have stood up a statewide consortium, if you will, of CIT officers, trainers, and CIT members, so mental health partners that are involved in there. We held our first statewide CIT conference last April. We'll be holding our second this April. The goal of this conference is the CIT training for officers is 40 hours. So they're in a classroom Monday through Friday. They're trained on all the primary mental health psychosis that they might be exposed to in the field, but not only what they are, but how to interact with somebody who's in the middle of one of those crises and be able to de-escalate that situation and then get them to the resources that they need. The conference goes beyond that 40 hours. How can we expand on the training that they're already receiving and share some best practices that are taking place other places? Due to the grant that we're operating under right now, we've been able to do that training for free. As far as the training itself, everybody responsible for their own travel. For our first conference, we had 102 in attendance, which for Wyoming, I think is a pretty good mark for your first conference. We've also stood up a CIT Wyoming website, so that's citwyoming.org, to serve as a landing page, if you will, for community members, but also it has a secure backside where our CIT members can be able to log in and again share resources and gain access to what is happening on there. We've expanded that site a little bit to include community-facing trainings also. So all of our CIT trainings will be listed on there, which is a select audience. But we have a lot of work taking place in our counties around suicide prevention and mental health awareness. We're using that also as a landing page to be able to put all those trainings on there so that our community members are aware of where they can become involved and how they can attend trainings along those lines.
Mr. Thompson.
Madam Chair, thank you. I would like to share some data points with you. So I think gathering this data kind of after the fact and maybe ongoing a little bit. So let me back up just a little bit. With the grant itself, it was easy to collect data as the grant proceeds. But we also understand that not all agencies are going to be using this grant opportunity. Several had already set up robust CIT training programs in their agency or in their area and continue to use that. Didn't need any additional funding. We're able to provide that training, so they weren't seeking any reimbursement or any of those things that we would track through the grant. So looking at the grant from inception to very recently, I think within the last couple of months, we've had the opportunity to reimburse agencies for the training of 254 personnel. So 254 personnel have benefited from this grant directly, and then the various agencies that they serve with. When we were having this discussion about CIT and how best to strengthen it in Wyoming, we started to ask agencies to voluntarily report data to us. I haven't updated this or haven't asked them to update this spreadsheet for almost a year, probably close to a year. But looking at the data that we had when we were talking with the Mental Health Vulnerable Adult Task Force committee meetings over the last two interims, we had about 30% of all law enforcement agencies in the state respond to our survey. Of those responding, about 50% of their peace officers were trained in CIT. About 20% of their detention staff were trained in CIT, and about 35% of their dispatch personnel. Now that's of the reporting agencies. So if we look at the total number of full-time certified personnel in those three distinct areas of law enforcement, we had about, at the time, 23% of all of our peace officers in the state of Wyoming trained in CIT. And that's actually a pretty substantial number, because CIT doesn't, the concept of CIT is not that every single person in the agency be trained in the 40-hour Memphis model of CIT, but having an understanding of it, having components of it through de-escalation training, mental health first aid training, other programs that kind of coincide with that. Yet you still have your personnel that are really kind of selected to be part of that team, that have those traits and characteristics that you want to be driving that bus in our agencies. So I would say that 23% of our peace officers statewide, 6% of our detention officers, and 9% of our dispatchers are all pretty good numbers, considering how really early we are into this statewide push for it. And then also we tried to capture some of this data from post records. So there's other training that goes on that might be unrelated to WASCOP. Not everyone is a member of WASCOP and participates in our training offers and things like that. So looking back in the previous years, our former director of post was able to pull some data leading up to 2022, indicating that now this would have been prior to this grant going into effect. We had 533 Wyoming certified personnel in CIT. They had taken some sort of post-accredited training in CIT. And then breaking that down, in 2019, there was 163 statewide. And then those numbers kind of leveled off for the next couple of years at around 100. And then in 2022, as this grant kind of ramps back up, we see this jump up to 181. So I think that data point today shows the impact that grant had even in the first 6 months that it was available. It was the highest year in the previous 5 that we had CIT training numbers that exceeded anything that we had been doing on our own before. And the premise with that grant was that as you look at agencies across the state and you send a peace officer or dispatcher or detention officer to 40 hours of training, that's an entire week off the schedule. That means someone has to fill in behind that position, and oftentimes that incurs overtime. So the reimbursement model that we were able to use with this grant helped them to bring in personnel, afford that overtime, afford the travel, afford any of the costs associated with this 40-hour training, which is, I'll say again, it's very substantial to get 40 hours of training for an officer that's responsible for a shift. So anyway, taking all those numbers into account, We're looking at 635 personnel through 2023, as opposed to that 250 some that were pursuant to this grant. We do see that several agencies in the state of Wyoming believe that CIT is important and believe that it's an important investment on their part, even if they don't need the grant funding to help secure that training. So, and with that, I mean, I'd be happy to answer any specific questions you might have about it, but I also want to turn it back over to Roy one more time just to make sure that he doesn't have any final thoughts before we answer a bunch of questions from you, Madam Chair.
Thank you, Mr. Thompson. Mr. Eckert.
So the national average or goal on the national level for number of officers trained in an organization is 25%. So we're pretty much right on target with what that national goal is and keeping up. And it is a challenge, as Alan referenced. There's in larger communities, CIT was built to be a specialized program. So it's similar to a bomb team or a SWAT team or any of those specialized teams where you would have specific officers on each shift that would respond. Majority of our police departments in the state and some of our sheriff's departments are lucky to have one or two officers on the street at the same time. So therefore, we don't have the depth on the bench to be able to have that specialized team. So therefore, we've tried to at least have someone on every squad that's trained in CIT. So there's usually somebody around that's able to respond to these calls. I will say another important component of CIT is being able to identify when you respond, is this a medical issue, is this a mental health issue, or is this a criminal issue? The majority of the calls that come into our dispatch centers come in as a criminal issue. When officers respond, often they find something different. And I like to share that. And it's, do I have the data to back it up? No, but I've seen it. In the numbers that I saw within my agency, pre-CIT and post-CIT, when a call comes in dispatch puts it out as it comes in. So it may come in as a disturbance, it may come in as a fight, it may come in as multiple different things. And it's not uncommon for when the officer clears the call, the disposition will be different than what the dispatcher gave out. So what we saw over time was, although our mental health calls kind of plateaued, the number of dispositions that were cleared as a mental health call versus a criminal issue began to rise a little bit. Officers will recognize this in the field. So being able to not necessarily use it as a get out of jail free card, there's still got to be the criminal issue dealt with on the side, but by recognizing the mental health issue and getting them to the resources that they need, we can cut down on those repeat calls for service and be able to address the underlying issue that's causing what's taking place. I will say in our trainings that we do, we see a huge turnaround in not only law enforcement, but EMTs. We do a lived experience on Thursday where you have a community member comes in that suffers from a behavioral issue, and it might be a substance use disorder, it might be bipolar. We have autism that come in and speak quite a bit. After 3 days of training and empathy building and getting some understanding what's going on in the background, the officer views that a little different than they did on day one. And I will say, as we had a peer support specialist that attended one of our training just to find out what it was all about. And she admitted afterwards that she was very nervous coming into that room and being present with these officers who she had been a victim of domestic violence. She had a substance use disorder. She didn't want to sit in a room full of cops for a week. And by Friday, she was like, can I get up and talk to the class before graduation? And she got up and said, you know what? I walked in fearing I would be judged and realized that I was the one doing the judging. Seeing the connections made, that makes us more effective in the community, which kind of goes back to that relationship concept also. And I'll partner with Alan there if you have any questions that we can answer for you around CIT.
Thank you, Mr. Eckert. I do have a question for Mr. Eckert. So we've heard a little bit from Mr. Thompson about some quantitative data, and I'm a fan of both quantitative and qualitative, but I'd like to hear a story, just Cliff Note version, Mr. Eckert, that you can give the committee of what you would deem as a success story. So I'm talking boots on the ground. Tell me about, or tell the committee about a situation perhaps where an officer a trained officer used their training and perhaps de-escalated or story of your choice. Please.
What I always like to share, and it wouldn't make primetime TV, but it's a great example of a goal of CIT, is we had a older female in our community that every time she would go off her medications, she would take a bottle of Hershey's chocolate syrup and paint pictures on the wall. And she was probably 80. Family members would call, we would go over and say, yeah, that's not right, but she's not a danger to herself or others. There's nothing we can really do. A couple of weeks later, she would become agitated, assault a family member. And now the officers are going over there having to drag an 80-year-old woman who's on the fight into the emergency room, often in handcuffs. Post CIT and that relationship building conversation with, and that's why I always say it's important that this is a community-based program. Okay, so we've talked about CIT in the academy. That covers the training, but it doesn't cover the relationship building. So post CIT, officer would get that call, go over to the house. She'd be painting the room in Hershey's chocolate. She would call over to Yellowstone Behavioral, which was our county mental health at the time, and say, I'm at so-and-so's house. Yes, I know you can't confirm whether or not she's a patient, but this is what she's doing. Both would acknowledge she's off her meds. Mental health would be able to intervene, get her back on her medications before we ever reach the point of having to take her to the emergency room or deal with the acting out. Another more dramatic one we experienced in Powell was a veteran, and he was several tours in Afghanistan. He was a special operations fellow, home visiting family members. And he had a very major flashback and had barricaded the house, was defensive fighting positions. It was not going to go good. We had 2 CIT officers respond. They were able to use their de-escalation training to interact with him enough to get him for him to get a moment of clarity. At which point he clarified that you need to handcuff me, you need to handcuff me now. And they did, were able to transport him to the emergency room, but they went beyond that. It was more than just that call that night. Through making phone calls to the Veterans Administration, they were able to find that he was actually receiving care in Colorado Springs and was on a release, but suffered from severe PTSD. Between the jail and our staff, they kept him company until they were able to send representatives up from Colorado Springs to take him back to Fort Carson. That was another one that could have gone south really fast, but the skills to intervene were there.
Thank you, Mr. Eckert. Did you have something to add, Mr. Thompson?
Madam Chair, thank you very much. As a former administrator that operated a jail, I think without looking at specific examples, I think we can talk about the impact or the positive change in the impact that you would have in the criminal justice system. I think what you've heard today is testimony that if we can intervene early and identify mental health as the root issue and not the crime that presents, then maybe we can get the treatment for the mental health and divert them into care that doesn't put them into the criminal justice system. I think we saw, like maybe a decade ago, you respond to a call of someone that's acting erratically and officers are not able to determine what their baseline is. They've never met them before, they haven't talked to them before, so maybe that's how that person is normally. And low-level violation of crime, tell them to leave the property, they've been trespassed. 5 minutes later, you get called to another business. 5 minutes later, you get called to another business. Pretty soon, they're going to make the determination to make an arrest to stop the issue that night. Rather than CIT trained personnel will look at the other resources in the community and use taking someone to jail as a last resort. And then it doesn't start that process with the criminal justice system. It starts that grassroots community process with law enforcement. And we've seen that a lot in just the reduction of people arrested just presenting mental health crisis. So I don't know how you collect that data because it's a non-data, I think also as law enforcement switches from the UCR, Uniform Crime Reporting, to NIBRS, which is National Incident-Based Reporting System. That's the new process that we use under federal and state law to collect data. That's been more expanded and it's more specific. So I think we might see in the years to come more data on mental health related things collected better from the initial point, because as Roy had mentioned earlier, you get dispatched to a trespassing, but you show up and realize that it's more of a mental health issue than it is whatever that low-level criminal issue is. So tracking that data, outcomes, the code clearance data is something that we want to tap into in the future to get a better understanding of this. Thank you, Madam Chair.
Thank you, Mr. Thompson. So as an administrator, Mr. Thompson, you have a grant administered through Department of Health. Obviously, access to care looks different in every community throughout the state. Mental health crises obviously exist across the state, and this is a unique tool for law enforcement to have in their belt to understand these different types of crises. Moving forward with the grant and identifying rural barriers that exist across the state, where do you foresee, and this question for either one of you, this program, where do you see it headed? Obviously, in larger cities across the nation, there's some departments that have cop docs that respond to these mental health calls, but that's not the situation here in Wyoming. How innovative do you foresee CIT becoming?
Thank you, Madam Chair. A couple of things on that point. CIT is something that we need to continue to train personnel on, because we're going to have loss of personnel, retirements, shifting of focus from that individual officer to another career field. I don't know what the word I'm looking for is, but within law enforcement, shifting out of CIT and into administrative roles or something else. So that constant need for ongoing CIT training is something that we're going to see in my entire career in this realm and for years to come. So I think continuing the whatever availability we can to maintain training mechanisms for CIT across Wyoming. We're already seeing what we refer to as co-responder programs popping up in some communities across the state, and you couple that with, let's say your mental health professional is working embedded within an agency, and that one person's gonna work 40 hours a week. If we made them available, or made 2 or 3 of them available 24/7, 365 days a year, you would need a pretty substantial workforce to pull that off, which is not generally supported in the calls for service don't need that kind of level of support. So what's the next option? And I think virtual care, virtual evaluation, and being able to have a resource that is available 24/7, 365 days a year through a connection on a laptop or a phone. And that is something that we are working diligently to provide across the state of Wyoming right now as we speak. And we hope to have those opportunities to kind of dovetail with CIT and all of these other things that we were talking about. And then also mentioning some of the conversations that we're having across the state about a mental health treatment court and what that impact could have. We see a couple of agencies across the state. We had a pilot program up in Campbell County, and then we see a couple of entities across the state trying to expand that in their communities. And what's nice about that is they know what resources they have in their communities and what they can do with their funding and availability of personnel. So what happens in Gillette is going to look different than what happens in Rock Springs and what happens in Cheyenne and what happens in Casper. And we might see some movement. And these are all, once again, supported by the state, but operated and funded by existing local government entities and partnerships with others. So those are the directions that we hope to see expansion and learn from those pilot sites. And then we're really excited to hopefully provide virtual care in the very near future.
All right, thank you. Committee, questions for Mr. Thompson or Mr. Ecker? Representative Wasserberger.
Thank you, Madam Chair. And I guess this could be answered by either one of you, but I'm just wondering, I notice with a lot of these types of folks that tend to get into these type of situations that kind of put them on the down of their luck. The attitude towards our police enforcement usually tends to be a little bad, unfortunately. I'm just wondering, with you guys implementing this, have you seen any type of enlightenment or slightly better attitude with this type of community, people that are kind of down on their luck? Have you seen improvements on the attitude towards our police officers? Has it helped?
Mr. Thompson.
Yeah, Madam Chair, I think Roy touched on this a little bit, and I'd invite him to also answer this with his experiences. But I think the one thing that matters the most is that community connection. When you're providing CIT in the community, oftentimes we're able to invite the media to the training session, have a conversation with students and instructors about what this program is, and it really builds relationships within the community on the front end of the mental health response. And then when these incidents do happen, and sometimes it doesn't look good for law enforcement based on the response that they have, and I don't think we expect the general public to understand that someone that presents as 150 pounds and 5'6" in crisis acts like they're 6'6" and 400 pounds of raw muscle, and sometimes force is used and it's ugly. It's just ugly all the way around. But building those relationships with the community on the front end and explaining the full scope of this helps then law enforcement explain those issues and the responses that they had during an incident. And I think we're seeing that a lot across the state, and communities are understanding that these mental health crisis points are sometimes could be dangerous, could be violent, and those types of things. So that's my general answer from my 3,000-foot level, I guess. Thank you, Madam Chair.
Additional questions, committee? Representative Yin.
Madam Chairman, Mr. Thompson, thank you. The CIT sounds great. I know and you mentioned this, that there are other communities that have pairing programs. So we have a social worker on our police department staff. Are there other communities that do similar things like that as well?
Mr. Thompson.
Yeah, Madam Chair, that's not a data point I collect, but I do know one other community, one county in the state other than Teton County does have, or in the last year, had what they call a co-responder model.
Additional questions. Representative Clouston.
Thank you, Madam Chair, and thank you, Mr. Thompson and Mr. Eckert. Your ongoing work after retirement, so this is a great program, so thank you. Question on the grant. Is it an annual grant that you have to apply for every year? Is it a ongoing? Tell me a little bit more about the funding model.
Mr. Thompson.
Yeah, Madam Chair, the grant originated in the spring of 2022 and was set to expire at the end of 2024. There was still funding left in that grant, so we were able to continue a portion of that through, I believe, the end of 2025.
It'll end June 30th, excuse me.
Oh, so we're trying to get, so that'll help us with the symposium that we have set up a month from now in Casper. And then throughout the end of June, then that funding ends, and we don't know where we would be at after that. We might be able to apply for an extension. I'm not sure that there will be much funding left in it at that time. But then, post June 30th, we'll be looking at other funding sources to continue CIT across the state.
Follow up, Representative Clouston.
Thank you, Madam Chair. Thank you again, Mr. Thompson. So I guess that's always one of my concerns. We start these great programs, the funding runs out, as they're up and running and getting better. So it's something we need to look at. But also, what's the relationship of this program with our school system and the SROs?
Mr. Thompson or Mr. Eckert?
Yeah, I might defer to Roy to answer that, because in my experience, SROs are just part of an agency that are part of this training. And I would see if Roy can answer that a little bit better than I can.
Mr. Eckert.
Madam Chair, Committee, I would agree that the majority of our agencies, SROs, are within the regular patrol staff. They're specialized during the school year, but the off season, they're a patrol officer again, so they receive the same training that the rest of the officers do. I will say CIT International is working on developing some additional training for SROs. So when that comes online, we'll look on making that available to our CIT staff. Also, if I may, I would like to go back to one question that was asked earlier on the community recognition of CIT, or does it affect the interactions? And I would say yes. In recognizing that, first off, a crisis itself is short-lived. The mental health or the behavioral health condition may be lifelong, but a crisis is short-lived. So we're dealing at a small moment of time. And depending on the level of reaction that they're having, that may or may not get a response. But when an officer graduates CIT training, they're given a CIT pen that they can wear in like their uniform. And our experience in POW was we had family members of people that were in crisis, or sometimes the people themselves seeking out those officers that were wearing the pins because they knew they had the training, the empathy, and the skills to be able to de-escalate the situation.
Committee, further questions or comments? Representative Heft.
Thank you, Madam Chairwoman. Good to see you again, Chief Eckert. During your time in Powell, did you see an increased escalation of mental health issues or encounters? And with this program, are we just seeing more because we can more readily identify the issues? Or is this something that's been going on for quite a while and we haven't been aware of it?
Mr. Eckert.
Madam Chair, Representative, I would say yes. In the grand scale, that the mental health issues have been here. Many were unrecognized. Many were unsure of what to be dealt with. So the officer dealt with the criminal side as opposed to just the mental health issue that was taking place. What we did see, though, was a reduction in repeat calls. So by addressing that mental health issue, we weren't getting called back to that specific individual on a regular basis. As far as what we saw in Powell, it ebbed and flowed because of oil and gas and migrant farm work and whatever may be coming in and coming out to the community. But as far as our constant community members, citizen members that were there year round, stress increases, things change. It's been there, but I feel like we were dealing with it better and not seeing the repeat calls.
Committee, additional questions? A follow-up, Representative Heft.
Thank you, Madam Chair. Chief Eckert, I've heard that there's a pretty good percentage in our jails of people dealing with different kind of mental illness. What would you say that is now?
The national average, and again, in the conversations I have around the country, it's that 60 to 70% seems to be the average of people that are in jails have some type of mental health issue. And that grows the bigger conversation. We talk SUD, the substance use disorder. That's a term I always struggled with until I learned more. We do better when we know better, right? Many of our SUD individuals are self-medicating for a mental health issue. So, Alan, as a sheriff, you might have better data what's in the jails in Wyoming, but I think we're right there in line with that.
Mr. Thompson.
Yeah, Madam Chair, I don't have the data at my fingertips. I know that the average when I was an administrator was around 40%, and it depends on what study you look at. Many of the studies look at diagnosed mental health disorder within the previous 1 year period. And I think we've heard some testimony down here earlier in the session from sheriffs across the state that have experienced higher numbers than that, looking at the 60 to 70% number that Roy had just testified to. So it depends on what data point I guess you're looking at, but do they present some level of mental health issue? And I think that's probably even higher than data would even show, because people are actually less willing to honestly report things like that, then haven't been diagnosed because a lot of the personnel in a jail just haven't been in front of a doctor or medical provider until they come into a facility. And often in county jails, that stint is a short-lived couple of days, so there's not time to expand on that mental health care and provide aftercare when we get out, which is another component that our membership is trying to work on, is that warm handoff. So from a health perspective, we're getting people into the jail and getting them evaluated and in front of a medical professional of some sort, a nurse or something like that, and then providing them with references to aftercare when they were released from the jail is something that our organization is hoping to expand on also.
Thank you. Committee, further questions? Representative Wasserberger.
Thank you, Madam Chair. Mr. Thompson, I'm just curious what the classes that you guys are teaching for the crisis intervention training. Do you guys teach like some types of psychology in there while they're there? Is there some types of trainings that are similar to social work, or is it a whole new thing that you guys have come together on to help with crisis intervention?
Mr. Thompson, or
Madam Chair, I'm going to give you a very short answer to that and ask Roy to give you a long answer to that. I've had the opportunity to guest instruct on certain topics in CIT when I was in Sheridan. One of them was the suicide response or suicidal personnel response. One was the concept of Roy's going to have to come up with the name for it, but drug-induced sudden death issues that law enforcement has experienced with someone that's using certain substances and then their movement is restrained. It's been in some places considered to be a causal factor in cardiac arrest and things like that. So just talking about some of those law enforcement specific responses coming from a law enforcement professional, and then I'll let Roy answer what types of other personnel give other portions of the class.
Mr. Ackert.
Madam Chair, Representative, so about 70% of the instruction is delivered by therapists from that local community, and they identify what you may see, what it will look like. We're very clear with officers and first responders that we're not training you to diagnose. What we're doing is we're training to recognize the symptoms and what that could indicate, and then how to interact with that individual to be able to de-escalate. Some of that even includes, and it's a stretch for law enforcement, person first language, some of the best stuff that's coming into place now, but to be able to recognize by the actions that they're seeing what that could indicate. A great example of that is schizophrenia. Somebody who's in a schizophrenic break is very, very difficult to communicate with, and it's very frustrating for an officer when somebody won't listen, when you're directing them to do something and they don't respond. We put the officers through an exercise called Hearing Voices. And in that was put together by NAMI. You put on a headset and you hear music that goes up and down, and it might be hard rock, it might be soft. In the meantime, you're hearing voices using all types of profanity, telling how dumb this is and why you're here. And while you're trying to negotiate that, you're given an exercise that might be a crossword puzzle or connect the dot or fill in the blank or something to keep you too busy to try and accomplish it. And while all that is going on, then you have an instructor coming to you asking questions, who's the president, who was the last president. So they get a chance to experience what it's like trying to interact with somebody with all this going on, noise and distractions and stuff taking place. So officers are trained to recognize what that schizophrenic break might look like. They've built some empathy because they've experienced what it's like trying to communicate with somebody in the middle of a break, and then taught the skills to be able to communicate with them. Does that answer your question?
Thank you, Mr. Ackert. Committee, further questions? Vice Chairman Ottman.
Thank you, Madam Chair. And I apologize if I missed this, Mr. Thompson. But when looking to expand the programs, do you go into like the city police, the county sheriffs, the town councils, the county commissioners, the mental health providers? I mean, how do you get into a community? And then do you find that getting the budgetary, because you're on a grant now, But to expand that and to keep that going, would that be conversations that all of the stakeholders need to see as valuable so that they do make it budgetary items? And then my second question is, do you find that this training could be advantageous for the law enforcement personnel themselves, that they can identify within themselves or within the ranks of their fellow workers possible breakdowns or problems?
Mr. Thompson.
Madam Chair, so our approach to advocating for CIT from WASCOP's perspective has been identifying the leaders in the agency that can be the champion in the community and empowering them and giving them the information to be that champion in their community to round up those the providers, the other people that you need to bring to the table to form a team and to build those relationships with their council or their county commissioners or whatever it may be. So we're focusing specifically on the law enforcement entity and their leadership or their personnel that have been identified as champions of CIT, and then helping them however it may be. If we need to come there and present to their council about it, or if we need to, what Roy's done a lot of is provide, coordinate the training in that community. So then he'll talk with them and bring in the local professionals. And if they don't have one nearby, bring in somebody from a neighboring county and put together this course. And then that really starts the community level conversation that we mentioned before that builds the support on the community level. And then the component of kind of like the peer support or the officer, and I would say all emergency responders, has been part of that CIT conversation and part of many other conversations that we have. So setting up peer support, advocating for agencies to have resources available for their personnel to meet with professionals, to have a little anonymity with that, to all those things that would help the officer. And that's another component that we're hoping to include in a virtual model. If we can cross that next bridge soon, part of that will be access for officers to that virtual care.
Committee, any additional questions? Representative Clauston.
Thank you, Madam Chair. Mr. Thompson, I don't know if you have any actual data or you can speculate, but I'm just looking at cost savings when we give someone appropriate care and placement versus just incarceration.
Mr. Thompson.
Madam Chair, there's some studies out there. I'm not aware of any in Wyoming. And it takes into account, this is also a broader conversation with some the issues that we had pre-session at the early beginning of the session about costs to sheriffs and jails for housing inmates that are slated for a bed at the state hospital. All of this comes down to if we can identify mental health issues on the front end very early in the process, and they're able to receive treatment and the treatment works and they're willing to stay in treatment, whatever that may be, for the long term, then the after costs of eventual hospitalization is never realized. So I think just looking at it objectively, there has to be cost savings. Getting a number on that, I don't know. Jail bed dates range, or bed space range from, we're usually billing around the $60 to $80 a day, but the actual cost for a bed in a jail overnight, without including substantial medical care, is well over $100 a night. And then some of the biggest expenses we're facing with people that are in serious mental health issue in jails is the medical care and the prescriptions and whatever accompanies that can rise into the thousands of dollars per day, but safely well over 200, 300 a day when medication is included in that. So, our hope is to identify early, provide opportunities for treatment, and not involve the criminal justice system unless needed. Now, I want to be clear that we're not talking about crimes against other people where they've victimized another human being, but property crimes, trespassing issues, low-level crimes that a victim would be looking for an immediate response to have this person no longer cause this problem, and they don't have any long-term impact from that. But we're still going to use the criminal justice system when individuals are victimized through violent crime and sort that out in the court system.
Thank you. So, Mr. Thompson, just following up on Representative Clouston's comment and question, it appears that the program in itself is really an approach that we're looking further downstream at issues. You guys are boots on the ground. You see the problems not only in your community, but in your home, and you're trying to resolve them. Is the program limited to just referrals to government agencies, or is it safe to say that officers cater towards resources that those that they come into contact with prefer? So in other words, if an individual that an officer comes into contact with prefers a referral to the faith community or so forth, is it limited in that, or is it more open-minded in that respect?
Madam Chair,
Mr. Ecker.
if I may. So another key partner in our trainings and the CIT program is our community prevention specialists. We're very fortunate in Wyoming that every county has a funded community prevention specialist that heads our substance use prevention and suicide prevention areas. And they also are a great asset to us for these trainings and for the program as they stand it up. The majority of our CPSs maintain a local resource list for their county. So that includes faith-based private entities, anybody within the county that's available as a therapist to their community members. Part of the training is we have the CPS present on what's available within the county, and then that list is provided to the officers to be able to make that referral. And also, if the individual has a request of a specific person, we will. I would also like to add on the cost-saving question. In addition to what Alan mentioned on the jail-based, our hospitals will tell you that they lose hundreds of thousands of dollars a year on mental health holds. So there's a cost savings there too, if we can avoid having to have that hold.
Thank you. Committee, any last questions? Representative Yin.
Madam Chairman, this may be slightly off tangent, but I'm just kind of riffing off of Representative Ottman's question. Something that I remembered from a ride-along I had a long time ago was that, it's a high-stress job being in law enforcement. And one where, I think that risks turnover because of the high stress of law enforcement as well. Do you think that we have adequate mental health resources for our law enforcement professionals now? And is there anything that the state could do to help work on that?
Mr. Thompson or Mr. Ecker on post-traumatic incidents?
I'll start, Madam Chair. The question is, do we have adequate resources? And I think possibly we have adequate resources. We do have a struggle convincing members of the law enforcement community that seeking help for mental health issues is acceptable in today's society. Is available. It's common. And it doesn't mean formal treatment, formal things as simple as peer support. So the level of processes that we can provide to our individual officers and advocate for it, and then have leadership set the example and be willing to say that they use these processes. So peer support, whether it be formalized or not, but having a conversation with someone that understands what it's like to be in law enforcement or in emergency services. So that could be fire, EMS, search and rescue, law enforcement, all of those entities, and being able to talk together through issues, and then taking away that stigma of treatment and providing resources. So I do think that the majority of our agencies in the state have probably adequate resources available, but I think our next step should be to overcome the stigma.
Additional questions? Representative Gugamas.
Thank you, Madam Chair. You said these grants were Department of Health grants. Do you know if those were federal grants or state general fund?
Mr. Thompson.
Madam Chair, I don't off the top of my head. I will take a look. The grant itself preceded me, so I wasn't in the negotiation process of it, but I'll see if I can find an answer and get it to you.
And
Madam Chair.
the director is in the audience if he'd like to help, if you want to phone a friend, we would welcome
I
that.
do
If
think
not,
Roy has an input, Madam Chair.
okay, all right, Mr. Eckert.
Madam Chair, it's both they were federal pass-through funds administered by the Department of Health.
Thank you. Additional questions, committee? Okay, seeing none. Anything further, Mr. Thompson?
Madam Chair, we just like to thank you and the committee for this opportunity to talk about this. Once again, I want to say how fortunate we are to have Roy and his expertise and his international experience on a daily basis continuing to drive this bus in Wyoming. And we're excited to see where we can go from here.
Thank you. So gentlemen, thank you for joining us this morning and thank you for the information. All right. Committee, we will move on to the next presentation. And I believe we have somebody joining us online. So for those that are in the audience, our body has received several documents from a group called the Citizens Commission on Human Rights International. And one particular legislative brief that was submitted to us by somebody by the name of Amber Rauscher. We each have a copy of these briefs in front of us. She is not able to be with us, but sent a substitute by the name of Mr. Toby Watson, who I believe will be joining us online. For those in the public, this brief that was provided to the committee has been submitted to LSO, and I believe will be uploaded online and available for viewing there. Mr. Watson, good morning. Thank you for joining us. It's my understanding you'll be walking us through this document or sharing your perspective on it. So please.
Okay, thank you. Can you hear me okay?
We can.
Wonderful. So I'll just give you a little bit of background for myself to introduce myself. My name is Dr. Toby Watson. I'm actually a clinical psychologist licensed here in Wisconsin. I'm the former chief psychologist for the Department of Corrections here in Wisconsin at one of the prisons and a statewide training coordinator for the whole state. I was very interested in your CIT training. I've done as a facilitator hundreds of officers throughout Wisconsin. It's an excellent program. Highly recommend everything that they were talking about. In addition, I've run a free clinic here in Sheboygan, Wisconsin. Did that for about 10 years as a doctoral training program. I became an expert in psychopharmacology outcome studies as it relates to psychotropic medications. I testify throughout the country. You're going to hear something about black box warning labels in a little bit. These things that go on medication in information sheets. I actually gave testimony to the FDA all the way back in 2004 when we got those added to the FDA. I've testified several times before the FDA. I've been an invited speaker to the Congress and the Senate of Mexico. I've helped with legislation in Australia, as well as other countries throughout the world. I was a former disability evaluator for the United States. And I currently still do some examination type work and risk assessment work. I do a fair amount of the active and school, or I should say school shooter evaluations and risk assessments here in the state of Wisconsin. Just to give you a little background on what I do. And I still do a fair amount of that kind of forensic work for people. I've also talked with the U.S. Veterans Administration on Health, talking about some very similar things that we're going to be talking about today as I review the information that Amber sent you from CCHR. And I'm affiliated with CCHR as an advisor, and I've several other boards that I sit on. So hopefully that gives you a little bit of background today. In addition, I donate most of my time by doing this. I'm actually a real estate developer, and I have a media production company as well. So a lot of what I do here is pro bono for doing this. So why are we meeting, and what are we talking about? This is basically done in the hopes, and she was giving you this information, the hopes to really raise drug awareness, for parents and teachers, or I should say parents and patients and the caregivers, often, state appointed, and give you a little background of why this legislation is important. And I'll give you just a little bit of background with regards to mental health. The U.S. spends over, $200 billion a year on mental health. Roughly 20%, 1 in 6 Americans are taking at least one psychotropic medication. The United States spends more on mental health than any other industrialized country. In fact, actually, of the next several countries, we spend more on that. 9 out of 10 people that walk into a physician's office with any kind of mental health issue walks out with a prescription. And interestingly, though, only 10% of them actually get referred to a mental health specialist. The new norm is that general practitioners and pediatricians write psychotropic medications, not specialists like psychiatrists or even psychologists in many of the states where we are allowed to prescribe. We've noticed a trend now where we've seen an increase where 2 or more medications are written. It's gone up over 60%, and actually over 33% now are going up to 3 or more medications when they are walking out of those offices. So the problem that we're noticing, though, and the thing that I think that RFK, talked about, and you heard some of this before by Sheila Gallo and Amy Miller, who had met with your committee just recently, and who had worked with Robert Kennedy, RFK, and talked about the mental health outcomes in the United States are actually going down, and they're getting worse. And in fact, UNICEF did a study and noted that for children's mental health, we're ranked 25th out of 29 of the industrialized countries. And we're wondering, why are we having the vast majority of school shootings? Why are we having the mass majority of our youth having these types of mental health crises and problems that we discover? And, our suicide rates, have skyrocketed. So when we look at it and say, well, what's the problem that here in the US we have the vast majority of mental health? We're spending more than anybody. We actually have the second highest level of income in the families for children. And yet we have this increase in violence, rage, and shootings and whatnot, and we're ranked down at the bottom. And I think one of the things that, came about that Sheila and Amy highlighted was that we know that, there's really no scan, there's no blood work, there's no thing that we can do to determine who does and who doesn't, quote unquote, have a mental illness. It's very subjective. It's a checkoff list that we use. And it's based on the DSM, which is the Diagnostic and Statistical Manual of Mental Disorders. This is the book that I use, that all doctors use when we're diagnosing somebody with that quote unquote mental illness. This is some of the training that we were doing in the CIT training that I had done here in Wisconsin, over an extended period of time. So that people understood some of this. And Alan Francis, who was in charge of the DSM, Dr. Francis was described as the most important psychiatrist in the world at that time. He was the chairperson of the DSM, an acquaintance of mine, and we've lectured together. And he acknowledged and said that, that these diagnoses are subjective. They're very misleading at times, and they're no more than really just descriptions of what we observe, and not actual real kind of diseases per se. This is what led to Dr. Thomas Inzel, who was the former director of the National Institute of Health, Mental Health. Again, this is the largest body in the world for research, and they abandoned using the DSM, saying that it was really just defining things, and it really lacked validity because they don't have any objective laboratory tests for that. And so why am I describing all of this, and kind of putting this out there, for you, that, hey, these are just kind of checkoff lists and things. I think part of the reason is that we have, and we know that there's things that cause people, especially children, because that's what we're talking about with this brief, is the Medicaid and working with children, and children specifically taking psychotropic medication. We know that things like poverty and unemployment, corporal punishment or physical punishment, sexual abuse, all these things can lead to an increase in violence and bad outcomes. But one thing that people hadn't really talked about a lot was that psychotropic medication can actually cause a worsening of outcomes and can cause people to become suicidal, homicidal, and violent and aggressive, and develop a whole host of true medical conditions, everything from, metabolic issues and diabetes and things of that nature to sudden death. So there's been more research coming out, with that. And I think probably one of the best ones was a gentleman, a friend of mine, Glenn Mullen and Moore. Back in 2010, they looked at the FDA database and they said, hey, let's just pull for like 18 months and let's look at all the medications that are out there, thousands of meds out there that can be prescribed. And are there certain medications that are the culprits that really cause acts of violence and cause these problems? And over that 18-month period, they found that there were, out of the 484 drugs, they said, hey, these are the ones that were reported that cause people to become violent. Where there's what are the top culprits? And out of the 484 drugs that they identified out of the thousands, they found 31. And they said these 31 drugs account for 79% of all the acts of violence. And of the 31, the most dangerous were SSRI antidepressants. 6 were sleep aids and anti-anxiety drugs like the benzodiazepines. And 3 were the stimulants, the ones that we most often give to children, like the Adderall and Ritalin and things of that. Mind you, 67% of that group, there was roughly just few of those drugs, those psychiatric drugs. They accounted for, again, almost 80% of all violence ever reported, during that period to the FDA. And it accounted for roughly 400 homicides. I'll say it again, 400 homicides, 400 assaults, 223 cases of other violence, and nearly 900 reports of homicidal ideation where they felt like they wanted to kill somebody else. Mind you, that doesn't include the thousands of people who become suicidal and then ultimately commit suicide, which in my world is, I call it a self homicide. It's a violent act towards oneself. And we know from the research that only 1% roughly ever get reported to the adverse drug reporting system with the FDA. So these numbers are just represent a small little fraction of where, hey, somebody was given a medication and then they had a bad reaction. They had the wherewithal to call their doctor and say, hey, I had this bad reaction. My kid, came in for some anxiety. I put him on this and he tried to hang himself, or I should say he tried to hurt his brother, beat him up. And then that doctor has to take the initiative to report it to the FDA. And so if you actually multiply it by the numbers, you're talking about hundreds of thousands of actual incidents of violence and negative outcomes. And so what we're recognizing that, that seems to match up with the research where we had, like in 2016, Sharman and others found like SSRIs increased aggression in children about 279%, so a 2.8-fold increase in them becoming more aggressive being on these medications. Prozac was increasing 600-fold increase. And so these are things that haven't always been made public. People don't understand it. You don't see it on the news a whole lot. And so the FDA kind of realized that this was happening. So they created something. The FDA said, hey, we know that parents don't always understand this stuff and caregivers don't understand this stuff. And they may not ever hear this or they don't even believe it. So they created these things called medication guides. And a medication guide is not the thing that you get stapled to when you get your prescription at the local pharmacy. Because if you ever get that, you do like me, you take it, you rip it, you throw it in the garbage, you don't ever look at it. Because if you open it up, it's about 4 font and it's using words like akathisia, which nobody knows what that is. So they created medication guides, which were very easy to read, just a couple page handout that were in big font, and they were meant to be for parents and for people like caregivers to say, hey, this is important information. You really need to know this about this medication so that you have informed consent. And that's what this is all about. This is about allowing parents and the child or, the teenager and any caregivers that's in the Medicaid program to really have informed consent so that when they say, hey, this is an option, you can maybe take this medication. They can look at it and say, wow, okay, yeah, I'm willing to do that, or maybe not. Because, some medications don't go along with other medications. And so sometimes doctors do miss that. And if the parent or somebody else says, hey, it says I shouldn't take an SSRI along with this other medication, but I'm already on it, they're like, oh yeah, you're right. Let's change it to something different. And this is really to reduce harm. This is the whole purpose of this brief. This is the whole purpose of the initiative of why we're doing this. And this comes on the tails of the executive order by President Trump, February 13th, saying that he wanted, again, quote unquote, make America healthy again. But the key directive was to say, hey, we want and recognize, and Robert Kennedy pointed this out, we recognize that, SSRIs, antipsychotics, the mood stabilizers, all of these psychiatric drugs, could and might be causing some severe problems and more metabolic issues for people taking them, and specifically children. And they're looking at it globally. We're focused on Medicaid because we have a responsibility through the Medicaid program saying, hey, if we're paying for this, we need to make sure that we have some accountability, some legislative oversight to say, are we actually knowing whether or not these medications are causing some problems, and how are they causing problems, and how are they really helping? And so this is what, through the Freedom of Information Act, CCHR, which is, again, Citizens Commission on Human Rights, gathered this data, and they put a lot of work into it at a lot of expense, to basically educate legislators like yourself. And what you got before you was basically the data on Wyoming, saying, hey, how many children are taking these psychotropic medications, and what categories are they actually taking? And then what is actually costing the state to have them on this? And the reason for this is to understand that there's a significant number of these medications that are not FDA approved for why they're being prescribed. So a lot of these medications carry obviously serious risk. That's why they got these handouts, these med guides, and they cause drug dependence and hallucinations and aggression. And they're not prescribing, FDA approved meds for these children. And this isn't to stop them from prescribing. This is simply to say, what are we looking to do? We're looking to create a database. So the question is, what is the goal? The goal is drug awareness, to have informed consent, to allow parents and caregivers within the state to say, hey, I'm aware of these effects. So if Billy or little Sally goes on a medication and all of a sudden you start to see something very unusual, you can say, hey, this might not just be a worsening of, quote unquote, their mental illness. This might be an effect of the medication, because I was informed and I actually signed a document saying, hey, I know this stuff. I know that this could be one of the problems. And to give you just an example, here's like one of the med guys. So again, it's just a couple page handout. It's got larger, I think some were included in the pack. This happens to be one on Ritalin. And it just basically tells you right out there, this is important information. And that has a very high chance for abuse and misuse, that it can lead to overdose and death. It's got a risk of increased, in higher doses, and people will sometimes snort it because, again, it is a class 2 narcotic. It's like the oxycodone, and it's like some of these other drugs that fentanyl that come over the border. And this is let them know that they could have a worsening of condition. They could hear voices. They could believe things aren't true. They could become manic. There's research to show that, stimulant medication increases the chance of mania by about 5%, and that's per year. So again, if a child stays on this for about 10 years, consistently on different stimulant medications, their chance of actually becoming manicky, which would be a high energy, not being able to sleep, running around, unable to stop talking, goes upwards of 50%. And people aren't aware of this. And so this is what they need to be aware of. So that's what these medication guides are about. And the idea is to have that the legislators become aware of it and create something in place following the executive order, saying that, one, we're looking for prescribers within the Medicaid system to say, hey, make sure that you give these med guides out and give them to a parent, print them and hand them so that we're aware of this. And two, create a database system that's very easy to manage, where parents can report the adverse drug responses. Right now, the adverse drug response reporting system is really, for the doctors to report to it. And we know that it doesn't happen. We know that there's a very low, less than 1% to actually get reported. But if we have one set up for the parents that are on the Medicaid system, we'd be able to have the parents say, hey, if you notice something, say something. because this is what we're trying to do, is basically get better quality care. And then ultimately, we're trying to have this align with the Medicaid obligation to monitor and improve the quality of care for this vulnerable population. And then basically, it would facilitate oversight and accountability, for them. So I don't know if your committee had gotten a chance to already look over this brief or look at any of these numbers. I'd be happy to share and talk a little bit about the number of prescriptions that are being done for the Medicaid population in Wyoming, or for that matter, any state, and here in Wisconsin, because I have those data too, and I can kind of give you some information about how it compares and what percentages and what it's costing you. So I'll turn it back over to you for any questions.
Thank you, Dr. Watson. Committee, any questions of Dr. Watson regarding the presentation or the legislative brief handout we received? Representative McCann.
Thank you, Madam Chair. Thank you, sir, for your testimony. Just wondering if you have any data on particularly kids, and I'm mainly ADHD, ADD, whatever you want to call it. What is the trigger for the child to see the doctor? Is it more of a parent bringing the child in, or is it more of the school saying they can't deal with the child? Do you have any data on that?
Dr. Watson.
Yeah, and there's studies out there that look at that. We know without any question that the number one way and path that children get placed on psychotropic medication, and really just even being diagnosed, is eventually through, or I should say, first step through the school system. Typically, parents ultimately have kids, maybe they're a little rambunctious or something, or running around. They kind of deal with it. But when they get to a school and they have to sit in a classroom, which again, we've only been doing for the last few hundred years, and they have to focus straight ahead, sit still and not wiggle around and do this thing that we ask them to do, that can be challenging for some. And interesting, there's been multiple studies shown that the number one predictor of who gets diagnosed in a classroom is actually the youngest child in the classroom. It's the number one predictor, because they become the one that's a little bit more rambunctious, the one that doesn't pay attention quite the same. And the teacher identifies them very quickly, like, hey, you're not like the other kids who are a little bit older than you. And then they usually tell the parent, hey, we're having a problem behaviorally with your child. I think maybe go do some counseling, maybe go, talk to the school counselor. Hey, other things going on in the home, talk to your pediatrician. And they have screening devices. There's a lot of screening devices, like Teen Screen was one that was put throughout the country, where they go down part of the curriculum that they take these little screening questionnaires and says, do you feel anxious getting in front of a class? Or do you, sometimes feel like no one likes you? Do you this? And if you ping high on it, it's got a pretty high false positive rate. So they ping pretty high. And then you get to talk to a social worker, and then they say, oh, I think I'm going to make a referral to, your pediatrician. And so at that point, then the second part kicks into that research that says, hey, 9 out of 10 walking into a doctor's office is going to walk out with a medication. And only 10% actually get before a behavioral health specialist, somebody who actually is going to work with them one-on-one. We like to think that it's actually the opposite. And it used to be. That study that I mentioned to you was done by Nicholas Cummings, who was a friend of mine. God rest his soul. He was the American Psychological Association president for many years. And he did that study in a 10-year period. He did one, and then he did 10 years later. And it literally went from 10% of the population walking into a doctor's office for children with any mental health issue. 10% got put on a medication. 90% were referred out to a mental health professional. 10 years later, he did the study again, and it was the exact invert. 90% got the med, 10% got a behavioral, intervention specialist. And so, unfortunately, that is kind of the state of what's happening now with like ADHD. And it's not to say that these don't work. Medications and drugs work really, really well in the short term. You can definitely take stimulants. We knew this since the 1950s with airplane pilots that were in the war. They would stay up and be able to focus very, very well. The problem is that we're recognizing that the long-term harm is that we're starting to see these aggressions. We're seeing a worsening of conditioning. We're seeing metabolic problems, true, physical problems. And this is why I think like Robert Kennedy and a lot of other people are recognizing that it's a fine solution for short-term But as a long-term solution, we're running into problems, and it's costing us a lot more in the long run because of all of these health conditions. And that's why that, health and human service pie of our tax dollar is so massive sometimes, and why we're seeing the Medicaid programs, like here in Wisconsin, it's literally, draining our system to the point of being the number one problem on a budget wise. I mean, your state, is a much smaller state, obviously, as far as population wise and utilization wise. But here in Wisconsin, we're talking upwards of $106 million in these medications that are being prescribed.
Thank you, Dr. Watson. Committee, any further questions? Representative Klauston.
Thank you, Madam Chair. Thank you, Dr. Watson. In the packet, we've been provided some model legislation. Has this legislation been enacted in any other states?
Dr. Watson.
So right now, this is all new, and we had just started submitting this, and I say we, although officially I'm not the spokesperson for CCHR, even though they asked me to present it, just because I'm an expert in this area of research. But CCHR has presented this legislation. There's 10 states right now that actually have it pending, and it looks very positive from the people that I've been talking with that this is going to pass, because this isn't a partisan issue. This is really just an issue of, hey, the president's directive, as well as just people in general recognizing that we need to utilize our funds better in mental health. Again, if we're spending over $200 billion a year and our rates are going down, and meanwhile we have 20 upwards % of all the kids taking these meds and it's still getting worse, we've got to figure out a different plan, a different solution. And so the first step in doing that is make sure they have informed consent. Make sure that the parent, the caregiver, the person taking care of these children that are very vulnerable to begin with, understand and can look for the problem and say, oh, this might be a medication causing this, making it worse. Maybe we should switch the med or try something different, more of a behavioral intervention or some sort of nutritional thing, or get some other lab work done. I can tell you that just based on the research, if I go into any psychiatric hospital right now, and I pull all the patients out and we do a full scan of labs and we really look at all the bizarre things that people can develop, from Lyme's disease to, hypothyroidism and things of that nature. If we go in and do that, according to the research, about 16 to 18% of all those people in there actually have a true medical condition that is mimicking a psychiatric condition. And when they treat the actual psychiatric condition, they treat the medical condition, the psychiatric condition goes away and there was no psychiatric condition. So we know that, we do occasionally miss things because, Occam's razor, path of least resistance. If it looks like it's a mental health issue, probably is. And that's what you go with. And we don't always look at the deeper underlying root causes of that.
Thank you. Follow-up, Representative Klauston.
Thank you, Madam Chair. And Dr. Watson, you mentioned pending in 10 states. Can you give me some of those states so that we can follow those?
Sure.
Dr. Watson.
One moment. Sorry, it's taking me to find out where I wrote my notes. I apologize, I don't have it right in front of me. If you want, I can send that to you right when we're done, because it's going to take me a minute to find out where I wrote them down.
Sure. Yep, email would be fine. Committee, additional questions. Representative Yin.
Madam Chairman, Dr. Watson, so I know you said you're not a spokesperson directly for this organization, but I'd never heard of it before, and so just a little Googling on their About Us website said that they're founded by the Church of Scientology. Are they still directly funded by the Church of Scientology? Do you know that?
So I don't know, because I haven't researched them as far as their funding in the past year or so. I know that historically that was a concern of mine, and I've heard obviously lots of negative things about the Church of Scientology, and I've never researched it in any way. Obviously, I'm not a Scientologist, I'm a Christian of my whole life, my family. And But I also recognize when I researched CCHR, they were funded by many organizations as well as other, Christian organizations, other philanthropists and stuff. I think part of their funding came from the Church of Scientology, simply because the CCHR group was really interested in human rights violations in mental health. And I think must have some overlap with that Church of Scientology group. But they are separate groups. The CCHR is its own nonprofit group. It's comprised of, like myself, doctors and lawyers and psychiatrists and researchers and things like that, that really just are looking at informed consent, human rights violations, and trying to improve mental health outcomes for people. So I hope that kind of clarifies the two a little bit.
Thank you, Dr. Watson. Committee, any additional questions? Representative McCann.
Thank you, Madam Chair. Dr. Watson, you touched on something as far as that doctor that did the 10-year apart study. Is anything looked at as far as, this didn't seem to be a big problem when I was a kid. So, I mean, as far as we learned to sit still in a chair. So what's changed since then to cause all this is, which I think Mr. Kennedy's on track with, our food's changed a whole bunch for sure. So I'm just wondering if anyone's kind of looking back, okay, what did we do back then as opposed to what are we doing now that's more than likely causing this problem?
Dr. Watson.
Yes, and there's some really good research out there, and which you're probably well aware of. So I'll highlight many things that I think that are causing a challenge for young little Billy or little Jill sitting in a classroom to have an increase in mental health disorders. One thing that we know is obviously it goes back to the home. We know that we have, like inner city, we have about 80% of Black fathers not in the home with their children. We know that the divorce rate is now upwards of 60%. We know that the food quality has radically changed, and we know that certain dyes can cause behavioral changes in children. We know that the caffeinated, high caffeinated drinks are extremely addictive, and that these kids often take that. We also recognize that it started to happen slowly, meaning that kids started being placed on psychotropic medications, and we saw a short-term benefit. We're like, oh, this works pretty good. And then all of a sudden we started seeing, the increasing more and more. Part of that is that, once, one starts to get diagnosed, then another gets diagnosed and another gets diagnosed. We know that there's been school interventions and a huge push by the pharmaceutical industry. And we have to really recognize that the pharmaceutical industry is not there solely to help people. It is there to create profit. And we're seeing literally thousands of % increasing in diagnosing and profits for them since the introduction, where they saw that children were a very good market. We saw that things like bipolar, which, again, I'm old enough to know this, and back in the day, bipolar was extremely rare. I mean, you'd be lucky if you saw one or two in your practice. Back when, go back 40 years, and then all of a sudden, the work of certain doctors who were paid by the drug companies really promoted bipolar in children. His name was Dr. Biederman. And we just saw that increase, skyrocket. So we know that the diagnosing has increased, the screening has increased, the problems of, the family unit breaking down, the food quality has changed, the fact that, some schools take recess out of schools, has changed. And there's an indoctrination. If you go into the curriculum, again, this is very deep how they do it, but drug companies will actually fund the people who write the books and some of the universities who create the research. So when the little Billy opens up his book in, let's say 6th, 7th grade, and it says, oh, this is the health section, it clearly says in there that ADHD is a true medical diagnosis and it's due to a chemical imbalance, and there's a genetic variability. Depression, anxiety is a chemical imbalance. It's a genetic variability, and that, that medication can often be helpful and whatnot. Well, what does that do to a child? Think about what happens with a child who's placed on a medication. And little Billy goes in, gets a med, and all of a sudden it works, and he calms down. He says, oh, the med's working. So when he's good, the med's working. But what happens when Billy acts out? What happens when he throws something or runs around or does something goofy? You don't blame the med and say, oh, the med's not working. You say, oh, Billy, you are the problem. You are getting a timeout. You're getting a loss of privilege. So if it does well, hey, that's good. Meds are working. When it doesn't, hey, Billy's punished. And so that is what we call internal locus of control. His internal locus of control is completely gone because he doesn't realize and he's not told that, hey, you can be in charge of yourself and you have the ability, to have self-control. You don't have to take a medication every day, which is, kind of a symbolic gesture in some ways if it's a placebo type med like an SSRI. But he's doing that and he's starting to rob himself of the hope and faith that, hey, yeah, I can really handle this. Now I get it. It can be extremely difficult. And then there's a lot of unusual experiences for young children. And they go through traumas. You see school shooters, on TV. Heck, I mean, that's changed in itself. Think about how your school system's changed. You got security, and you've got metal detectors and you're doing active shooter drills. And I mean, when that started, I remember my daughter was about 4 or 5, let's see what she was, 6, 7 years old. And she came home and didn't want to go to sleep that night because the school didn't tell me that they were doing an active shooter drill. And she came home terrified, didn't want to go to school the next day, and she didn't want to go to sleep. I went to my school district the next day and said, I can't believe you guys did this, and didn't inform the parents. So there's a lot of factors that have changed. But I can tell you this, that, the brains of these children really haven't radically changed from at least birth anyway. What we're doing is that we're having children meet the needs of our school systems and our society rather than the society and the school meeting the needs of children. And so I think this is one way to kind of help meet the needs of kids by having this legislation, because at least it'll give it a reporting system and ensure that the parent and the caregiver says, hey, I'm aware, we're going to try this medication, we're going to see if it's helpful, and maybe it will be, it'll be great, which again, I support it. I've been very supportive of medications at times. But this way, at least we can know and say, if there's a problem that comes up, you should be aware of it because you were told about it. And that, will also help us with tracking a little bit to really get the numbers and say, okay, well, how bad is it? We don't know how big is the problem, but this will at least give us some data for it.
Thank you, Dr. Watson. Committee, any additional questions? Okay. Seeing none, thank you for joining us this morning.
Thank you. I appreciate it.
Okay. Yep. All right, committee. It is 9:45-ish, so we will conclude this meeting. Thank you very much, and thanks for those in the audience for joining us.